Hello, everyone, and welcome to today's MSP Lunch and Learn webinar. I'm really glad that all of you are able to join us today. And before we get started, I want to go ahead and just give a couple of brief housekeeping items. First, everyone is on a global mute, so if you do have questions or need assistance, if you could go ahead and just enter them in the chat box, and I will be monitoring that throughout the webinar and will help with any technical needs that you may have. Also, feel free to ask questions throughout today's presentation. We will be addressing those as we get to the end of the presentation. So feel free at any time to go ahead and enter those into the chat box. A copy of today's slide deck is in the handout section on your control panel. So if you want to open that, you're able to download the slide deck. And just as a note, we're noticing that there are some issues with Internet Explorer, so you may need to open that in a different browser. But I will also be sending a copy of it out after the conclusion of today's session. So with that, I'd like to go ahead and introduce our presenter for today. We have with us today Cass Sharon, and she is with Disability Rights North Carolina, and she joined them in 2007 as an advocate. As the director of the agency's investigations and monitoring unit, she oversees the investigations of serious allegations of abuse or neglect for individuals with disabilities. And that includes doing things like supervising the protection and advocacy for beneficiaries of the Representative Payees Program, as well as with the Disability Rights NC Disaster Relief Project. For the 8 years before she joined Disability Rights, she, in pursuing a career in advocacy, she reported for newspapers in both Georgia and North Carolina. And she's also worked as an investigator, consultant, administrator, and legislative liaison for a Durham nonprofit law firm that specialized in defending people facing the death penalty. And she did that for 15 years. So one of the things that drives Cass is that she's people whose humanity and dignity has been overlooked or discounted by others. And it is my absolute pleasure to have her here today to be working with MFP and providing some information to all of you. And at this time, I'll go ahead and turn it over to you, Cass.
Great, thanks so much. I can't tell you how excited I am to be with everyone today and to be invited to present about this topic of trauma-informed approaches. I'm a lifelong student about trauma, so I'm delighted to be with y'all today. Before we get started, I want to just stay on the slide for a minute and introduce those of you who may not know about Disability Rights North Carolina to our agency. We're a statewide civil rights nonprofit law firm that's part of a national network of protection and advocacy agencies. It's called the P&A system. Each state and territory has a P&A. We're funded primarily through Congress, so we do have some private funders, and we're always grateful for those because they expand our capacity to do our work. We are the only agency in North Carolina that is statewide that is focused on advancing the rights of people with all kinds of disabilities of all ages. And we do this in particular areas, and I want to just briefly give y'all an overview of our work. Tracy mentioned investigations and monitoring. The federal law that created the P&A system gave us access authority, a federal authority to be able to monitor in any settings where one or more people with disabilities receive services. We do that to ensure that people with disabilities know what their rights are, as well as to prevent, detect, and address instances of abuse, neglect, or exploitation. That same authority also allows us access to records and people in order to conduct investigations of abuse and neglect. Beyond the investigations and monitoring work, we also work to keep students with disabilities in school and that they attend school free from abuse, including abusive interventions. We advocate for the employment of people with disabilities in competitive and integrated jobs. We enforce the right of people with disabilities to have equal access to their community. We're working to reduce North Carolina's over-reliance on private residential treatment facilities, PRTFs. We work to reduce unnecessary institutionalization of disabled people and advance home and community-based health care services and supports. And MFP is one of the tools in our toolbox when we are helping people out of institutions, if it is an institution where that might be a service that is available. We work to increase access to accessible, affordable housing for people with disabilities in communities of their choice. We prepare, advise, and for people with disabilities before, during, and after a state-declared disaster. We advocate for safe, equitable, and just criminal processes for people with disabilities. We promote the right of self-determination. We enforce the right of people with disabilities to vote. So you can imagine our voting team is very busy these days. We ensure the individuals and organizations appointed by the Social Security Administration to serve as representative payees are administering those benefits for the benefit of the disabled person, and that they aren't abusing, neglecting, or exploiting those in their care. And then finally, because we are not able to help every caller or every person who emails our intake department, because we simply don't have the capacity, or the callers might be coming in from areas of focus that we're not focusing on. We have a very robust information and referral unit. And so that is overall the work of our agency. We have a wonderful website, just got uplifted. So please take a look at it, and that will give you more information about our work as well as examples of our work. And please do help spread the word about Disability Rights North Carolina. We do very much want to help people. So Christina, can you move us to the next slide, please? Okay, so our agenda for today, first of all, I want to go ahead and do a shout out for next month's webinar, which is going to be on October the 12th. And that will be Dr. Jill Hinton, who will be presenting from a clinical perspective about trauma. And Dr. Hinton is one of my mentors. I learn so much from her every single time I have the opportunity to hear from her. So I highly encourage you to tune in and sign in for that one. So today we're going to be talking about trauma-informed approaches and understanding what is that in comparison to trauma-informed care, what's the difference. We're going to talk about trauma and the prevalence of it, consequences of trauma, what trauma behaviors may look like, and you see those are in quotes, what we can do, and possible outcomes with trauma-informed approaches. Next slide, please. So why a non-clinical perspective? Here I want to bow to another one of my trauma mentors, Dr. Kevin Ann Huckshorn. She taught me that treating people well is a best practice. We don't have to be clinicians to do that, but being trauma-informed can help us understand better how to treat people well. So in our work, monitoring in facilities, conducting investigations, and representing individual clients, we see trauma behaviors as well as history. And when I talk about monitoring in facilities, I just want to give y'all an overview of the types of facilities we're in. We regularly monitor in most of the state-operated facilities. We're also in adult care homes, also known as assisted living facilities. We're in skilled nursing facilities. We're in psychiatric residential treatment facilities, the aforementioned PRTS, the locked facilities for kids. We're in day programs, we're in group homes, we're in family care homes, we are in schools. I mentioned we're doing school work, we're in jails, we're in prisons. So we're in many different settings where people with disabilities receive services. And we often see that there is unrecognized and untreated trauma that is evident in the lives of the people that we see. And I want to say here that while I'm focusing on non-clinical approaches, you know, how we work with people with trauma histories, that I can't stress enough the importance of recognizing trauma and then getting treatment for the trauma. So this is in no way meaning to substitute a non-clinical perspective for a clinical perspective. This is rather just a way that we can all be on the same page about how we can treat people who we can assume have trauma histories. Untreated trauma can lead to institutionalization, a loss of hope, and lowered expectations in life. So I want to lift up for you for a moment, a young woman that we met when we were monitoring in an adult care home in a very rural part of North Carolina. She was in a wheelchair. She was in her mid-20s. She was incontinent and therefore wearing diapers. She was kind of slumped over. She was drooling. She was sort of in and out of conversation. And the longer we worked with her, she wanted to move out of there and move into the community. The longer we worked with her, we learned that she had an intellectual disability. She was able to graduate from high school, and she had employment. But then she began a series of involuntary commitments. And with each involuntary commitment, you know, when a person is involuntarily committed, they're sent to the hospital that has an open bed. So it may not be nearby where the person lives. And so with every IVC and her discharge, she was discharged further and further away from her home and her natural supports that led her to be in this place. So we helped her get out. And at the time we met her, she was on 17 different meds. After a review of those meds and a slow reduction in those meds and many of those meds, she no longer needed a wheelchair. She was no longer incontinent. She was no longer drooling. She was bright, shiny, ready to go every day and greeting every day. So we were really happy to be able to help her, but she clearly had a trauma history that had not been recognized or treated. And as a result of that, that's where she wound up. And many years of her life, of her young life, were carved out because of that. So we believe that if we just simply assume trauma, that we're increasing opportunities for people to have better outcomes. Next slide, please. So approaches versus care. Some people wonder, you know, is there a difference? And there really isn't. You can use them interchangeably. What we've come to learn is some people, when they hear trauma-informed care, they might be turned away from it because they don't consider themselves to be in the caregiving business. So consider, for example, homeless shelters or disaster shelters or jails or prisons, even employment considerations. So we have decided that using the word trauma, the phrase trauma-informed approaches is a more holistic, more umbrella concept that is focused on how we interact with one another. And there could be clinical underneath that umbrella, but it doesn't equal clinical. So that's the way we think about this. And so next it's basically how we communicate and interact with each other, how we treat people, just plain and simple. So next we have a poll coming up, I think.
Yep. All right, let me go ahead and launch that. All right, so you should be seeing the poll, and the question is, where are you in your understanding of trauma? 1, this is a new concept for me. 2, I have a general understanding and want to learn more. 3, I'm very focused on trauma and want to learn more. Or 4, put me in, coach, I can lead this webinar with you. So we'll give everybody just a moment to cast their vote, and it looks like we've got almost half the group that have voted so far. So we'll just give it a...
Yeah, I was just going to add in a couple of comments while people are voting, if that's okay.
Sure, go ahead.
I find that on any given day, I mentioned earlier that I'm a lifelong student of trauma, that on any given day, I generally fall between 2 and 4. I learn things almost every single time I'm tuning into a webinar or reading an article or looking at research. And the science and the research is changing rapidly, and that's great. There's more and more work that's being developed. But as I learn, things might settle in differently, or I might learn a new context for what I do know about trauma. So I want to encourage y'all that this webinar, there's nothing magic about me having the talking piece today, except that I do, but I consider, this to be a learning community. So I would encourage y'all, if you don't mind, please use the chat to put in good experiences you've had using trauma approaches. And if we have time at the end, we want to go through those with the group. But if we don't have time at the end, and if we have additional questions or whatever the case may be, we will follow up, and because we want to share this information with everybody, because I think that we learn best when we're in community, and everybody has their own great experiences to share. So I'd appreciate it if y'all would participate with me in leading this seminar. Do we have any results yet?
Yes, we do. Let me go ahead and close out the poll and share the results. All right, looks like the group said this is a new concept. About 2/3, 67%, said they have a general understanding and want to learn more. About a quarter are very focused but still want to learn more, and then 3% consider themselves kind of an expert in the field. So pretty interesting spread of responses there.
Yeah, that's great. Thank y'all. I hope this will be a meaningful hour for you all. So thank you all for tuning in. Christina, if you're able, can we go to the next slide? Okay, so this is SAMHSA, the Substance Abuse and Mental Health Services Administration, which is part of the U.S. Department of Health and Human Services. SAMHSA has been studying trauma and teaching about trauma for many, many years. And through the years, they've worked with a lot of experts, and they have come to promote a that is the 3 E's. And that is that individual trauma results from an event or series of events or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. So it's an event, but it's important to understand this experience, because this trauma is very individualized. This is what helps determine if something is a traumatic event. So what might be traumatic for one person may not be traumatic for another. So it really does matter how an individual experiences an event that will contribute as to whether it is traumatic. And the effects piece is the long-lasting effects is the crucial component to this. The effect can occur right immediately after an event or circumstances, or it can have a delayed onset. So it's really important to understand the concept, but it's also important to understand the prevalence, because it's far more prevalent than we might imagine. Next slide, please. So the adverse childhood experiences are commonly known as ACEs, and many of you all might have already heard about these. They came from a study that was done over the course of a couple of years through 95 through 97. 2 doctors, Dr. Vincent Folletti in California and Dr. Robert Anda at the CDC in Atlanta, didn't know each other, and in their work they were beginning to see some patterns that made them wonder if the adults that they were seeing and the physical and mental health conditions that they were treating, if they were in any way related to any childhood experiences. So they got together with Kaiser Permanente, and Kaiser Permanente agreed to put out a survey to 17,000 of their members. And they embedded in those surveys 10 questions. Among all the many questions that were being asked, they put in 10 questions that focused on abuse, neglect, and household challenges. So for abuse, they asked about emotional abuse, physical abuse, or sexual abuse. For neglect, emotional neglect or physical neglect, and household challenges, whether the mother was treated violently, substance abuse in the household, mental health issues in the household, parental separation or divorce, and whether there were any incarcerated family members. Now, remember I mentioned that this was given to 17,000 Kaiser Permanente members. The demographics of them were roughly half were women and half were men. Nearly 75% were white. The average age was 57. 75% had either graduated or attended college, all had jobs, and all had health care by virtue of the fact that they were members of the Kaiser Permanente organization. So the results so astonished Drs. Anda and Felitti that they asked the people who compiled the results to go back and redo it. They wanted to make sure that they were not that something hadn't gone terribly wrong in the calculation of the results. Next slide, please. So what they found, and the results did not change, and what they found was that the ACEs were common across all populations. Nearly 2/3 reported at least one ACE. More than 1 in 5 reported 3 or more. So as we look at, there are almost 350 people on this call. What does that average out to be? More than maybe 60 or 70 of us, I'm not good at math, on this call would have had 3 or more, if I've got my math right. Women in some racial and ethnic groups, greater risk for 4 or more types of ACEs. And the reason this is important is that the research shows that the more ACEs a person experiences, the greater the impact on their physical and mental health. And so if you go on the CDC website, Centers for Disease Control and Prevention, you can see all the graphs about these data and how they played out. And it's interesting to know that the research and the studies didn't stop with this. In fact, they continued. And what they find is across wherever the studies are being done, we come back to almost the exact same results every time, if not the exact same. So it's incredibly important to know about that. The other thing that's important to know about is the 10 areas that they focused on as being questions about trauma in the ACEs study are not exclusive. So trauma, remember I talked about how trauma is individualized. It matters how a person experiences something that happens. So it could also include accidents, natural disasters, witnessing acts of violence, cultural, intergenerational, and historical trauma, grief or loss, medical interventions, war, other forms of violence, poverty, racism, homelessness, bullying, being sent to jail or prison, being in foster care or juvenile justice systems, loss of a caregiver, such as a mother or a grandmother, etc., and survival and recovery from a severe accident. Now, these are, again, not exclusive because it's individual, but I just want to make sure that people, when you leave here, please don't think it's just abuse or neglect. It's a much broader category of events that could be considered traumatizing. Next slide, please. So these are statistics from the National Council for Behavioral Health. 70% of adults have had a traumatic event at least once. In the US, a woman is beaten every 15 seconds, and a forcible rape happens every 6 minutes, and more than 33% of youth are exposed to community violence and will go on to develop PTSD, post-traumatic stress disorder. But I also want to really focus on that second bullet, the one that says 90% of public behavioral health clients have experienced trauma. My guess is that a majority of people on this call today are in the public behavioral health service industry. And so that is just an astonishing statistic there that is important for us all to know moving along. Next slide, please. So continuing on with the CDC information, the consequences of trauma can have lasting effects on health, well-being, and opportunity. You can read the slide. Increased risks of all these areas of concern, increased risk of death from cancer, diabetes, heart disease, suicide, many other chronic diseases. And these are just a few examples. It can also result in distorted cognitions, anxiety, difficulty concentrating, sleep, substance use, self-injury, poor judgment, continued cycle of victimization, depression. Next slide, please. So difficulty forming healthy and stable relationships and unstable work histories, lifelong problems with finances and jobs, food insecurity, frequently moving, living in under-resourced neighborhoods. These are just a few. And these can also cause toxic stress, which is extended or prolonged stress. Now, some of us on this call, certainly this pandemic and the way we've had to work through it, we could consider that to be extended or prolonged stress, but we have to consider that in the context of whether the stress is experienced without any support system in place, not even one person, and where the individual is left to flail and figure out how to process what is happening. And so the importance of toxic stress is that it can actually change the way the brain develops and can affect attention, decision-making, learning, thinking about children in school, impulse control, responses to stress. And some children can have further exposure to toxic stress from historical and ongoing traumas, such as those that are due to systemic racism or the impacts of poverty that are resulting from limited educational and economic opportunities. And all of this is from the CDC. Next slide, please. So untreated and unaddressed, we talked about cycling in and out of institutions, the unnecessary use of restraint and seclusion, psychotropic drugs, the criminal justice system, jail, prison, homelessness, the list can go on. Next slide, please. So let's talk about what some of these quote unquote behaviors may look like. What some may consider an outsized response. Another one of my trauma mentors told me one time about a young lady that was in her care who would have these inexplicable meltdowns. Like they could not figure out what was happening. And then when they did a deeper dive into her history, they found out that she had been ritually raped by someone with red hair as a child. And every time now they were able to figure out that every time she had one of these responses, she either saw someone with red hair in real life or that someone with red hair was on the television screen. And so they were able to understand the context of what was happening to her and understanding that all behavior has meaning. It can result in angry outbursts or aggression, hypervigilance, the opposite, non-responsiveness, failure to comply, risky behavior, and poor judgment. So all of these are a means of communicating unmet needs. Next slide, please. So I'm going to give y'all some examples. All of these involve people that I know to have a trauma history. And so the first fellow was a long-term patient at a psychiatric hospital. And when I came onto the unit that day, he was pacing. He is normally a very docile, sweet, kind man who puts others before him. And but this day, I could tell he was agitated, and he ultimately went up to the nurse at the desk. She was back there behind her desk, behind a computer, and said he needed a smoke break, and she ignored him. And so he walked off and started to mutter, and I could tell he was getting, you know, a little more ratcheted up. And he was walking back and forth, and he finally went up to her again and said, "I need a smoke break." And she told him to go away, that she was too busy. So now he's really ratcheted up, and he's really very forcefully walking back and forth and back and forth. And finally he goes up to the desk and he slams his hand down on the desk and yells out that he wants a smoke break. And now she's yelling back at him, and they are in a full-out yelling match that ultimately was resolved, thankfully, without the use of restraint or seclusion or an injection of a psychotropic med, a PRN. But that could have been handled so differently if the very first time he went up, that she greeted him by the name he prefers to be greeted with and explained, you know what, it's a holiday weekend, we're short-staffed, and these are all things I came to find out. We're short-staffed, I'm on a deadline to get this report in, but I can help you in 15 minutes. Can you hang on for just 15 minutes for me, and then I will help you? And that would have been all it would have taken to have prevent what happened instead. She just wanted to talk with her mother. This was a young lady who was in a psychiatric residential treatment facility, one of those PRTFs, a young teenager, and it was time for her to call her mother, and she went to the phone to call her mother, and her mother wasn't there, and she was upset. And all the way back to her room, she was emotional and crying. No one was trying to intervene on her behalf, to give her comfort, to reassure her, to say, you know, don't worry about it. I understand why you're upset. We'll try back in another hour. And in the meantime, let's think about, you know, your coping skills, because I am a staff member who's very trained, and I know what's in your file, and I know what helps to help you feel calm. And so let's pull out some music and listen to some music, or play some cards, or would you like to play a board game? And I'm going to be with you. But instead, she was left to handle her emotions herself, which continued to escalate. And when she got in her room, she began throwing things that resulted in several staff taking her down to the ground and restraining her face down for more than an hour. He just wanted to have agency over his life. So this fella was in a wheelchair. We met him in an adult care home, and we were able to help him transition out. We were able to get him a waiver slot, an innovations waiver slot. But the care coordinator was so maternalistic over him, this grown man, that he didn't want to have that oversight. She was requiring him to go to a gym and keep the apartment clean to her standards, and several other things that he just was not interested in doing. And so he literally gave up an innovations waiver slot rather than have someone have that amount of control over his life. She just wanted to take care of her children. This was a woman who neither she nor either one of her adult children with autism had services. So we were able to connect them with the MCO, who very rightly, this was good news, did a trauma assessment, but unfortunately did not tell our client what the purpose was of the questions that she was being asked, or even what their individual role was in asking those questions and the importance of those questions. And so our client called us up and was crying and mad, very angry, and felt that she had been blamed and shamed about the way her children had grown up, and indeed the way she herself had grown up, and that she wanted no part of any kind of system that would treat her in such an accusatory, the way she felt it landed, way. Well, we ultimately were able to find out that it was indeed a trauma assessment, but it had been bungled very badly in the way it had been administered. Next slide, please. So what can we do? Use universal precautions. Now that we know how prevalent trauma is, there is absolutely no harm in going ahead and assuming trauma is present. Be attentive and respond quickly to problems. Recognize that conflict or violence arise most often due to situational factors you might be able to control. If you think something's going on, pay attention to it. You may not be an expert, but you have a voice. Acknowledge prevalence, assume it's there, and come from a place of genuine openness, and build trust and safety. And that's what this is all about, is building safety and building trust. Using the platinum rule, treating people as they want or need to be treated. Read your files. Very likely you have information. You may even have a trauma diagnosis in your files for your clients that you have maybe missed or not been able to get to yet. Or you may have social histories in your files that very clearly point to a strong indication that there is a trauma history, and you want to be able to pay attention to that. You want to show empathy and actively listen. Be patient, take the time that the individual needs. About what they're telling you, that this sounds, I'm so sorry that this happened to you, and I wish I could have made things better for you when this happened to you, but we're going to work together moving forward. Transparency, manage expectations. Don't surprise people with changes if you can help it. And if you can't help it, own that. I am so sorry. I know this is coming as a surprise. It came as a surprise to me too, but we're going to work together to make things work for you in the best way they will work for you. Allow families, loved ones to participate if your client wants them involved. So one of the things I want to make sure, when I talked about the behaviors on the previous slide that were clearly not trauma informed, trauma systems and care, areas of care that are not trauma informed are those that sort of impose power, impose control, impose authority and enforcement. They also are real big on labeling. So think about, sometimes I've seen numerous records where someone is listed as manipulative or needy or as attention seeking. So I want to really kind of think about what those words are really transmitting and how we can turn them around to become more trauma informed. Next slide, please. So I mentioned building safety and adopting a customer focus or service approach. Building safety, everything in this section of what we can do is to build safety. Adopting this customer service approach. Ask people, for example, what they prefer to be addressed and use that moving forward. So, for example, my name is not Cass, actually. That's my nickname based on my full name initials. I am really Cynthia Ann Sharon, and I'm not happy when someone calls me Cynthia or Cynthia Ann. It's a beautiful name, and I adore my parents for giving it to me, but my whole life I've been called Cass. And if someone calls me Cynthia or Cynthia Ann, that signals to me they don't know me. They don't know who I am, and they've not asked who I am. So even little simple things like that. Let's be aware of our own responses and interactions with people. We can have trauma histories too, and we might be triggered by the way someone is responding to us, and we need to be aware of that. On the previous slide, I talked about the trauma assessment. Explain our role and our actions. Don't assume that the people that we're working with have any idea who we are or what it is that we're there to do. Show respect. And then Tony Kane, if you've not heard of her before, please take a few minutes after this is over to Google her. But she is a phenomenal individual who survived decades of significant childhood and adult abuse, neglect, and exploitation. And she cycled in and out of prisons, jails, and psychiatric hospitals for decades, as I mentioned. And she said she was on a collision course for that to be the rest of her life, until one day someone asked her, instead of what's wrong with you, they asked her what happened to you. And things began to change then. They began to drill down and talk about her trauma history. But before that happened, the systems themselves were really traumatizing. She talks about when she would be involuntarily committed, that her diagnosis on admission would depend on who the doctor was, who wasn't listening to anything that she would have to say. And she would say that she would have bipolar Tuesdays or schizophrenia Saturdays based on the day that she was in there. So we just need to pay attention to our clients and learn what they can tell us. Next slide, please. There's also environmental concerns. So think about your offices or your environment whenever we're able to be back in our offices. The physical environment, when someone comes in the door, is it someone behind glass who has to buzz them in? Is it a locked facility, locked greeting? The personal greeting, is it a handshake, eye contact? Would you like some water or coffee? What does the environment itself look like? Soothing wall colors or images that are calming in the artwork? Try to have individual seating if at all possible, and also individual seating that's comfortable, because people who have trauma histories do not like to be sitting next to strangers. They like to have their own place to sit. They feel safer that way. Also, try not to have anybody that has to sit with their back to the door. Make sure that the furniture placement maximizes view, and make sure that it's not dirty or cluttered. That could convey a lack of care. So all of these things are meant to be in more a partnership with people, to honor who they are as individuals and to treat them with respect and humility rather than control and power, greeting people from behind glass with keys and uniforms ensconced in a big desk, sort of othering them in that type of environment. Next slide, please. So other things we can do is continue learning. There is literally no end to the information that's out there on being trauma informed. Please seek trauma assessments for your clients. Ensure your staff have a full understanding of trauma and its consequences. Become a trauma informed practice. That's a real thing. There's an actual designation for that. And spread the word. Tell everybody you know about this. Next slide, please. So the benefits of being trauma informed is clients can be engaged and get the treatment and the services they need so they can lead safer and happier lives. Increased safety for everyone due to lowered stress and anxiety for both clients and staff. Significant reduction in the use of seclusion, restraint, medications, and other coercive practices. Improved participation in treatment programs, shorter lengths of stay, improved patient follow-up, fewer adverse incidents, fewer people living in congregate care. Instead, they're living in the communities of their choice. Fewer physical injuries for staff and workers' comp claims, safer, healthier work environment, and a cost savings, a reduction in the use of drugs and the use of institutionalization, increased opportunities for employment, education, etc. Next slide, please. So I wanted to leave y'all with 2 slides with resources. Literally, I told you there's just such information out there. If you haven't yet seen the documentary Resilience, please find a way to do that. It's 59 minutes long, and it is just a phenomenal introduction and reintroduction, if you will, for me it was, to the importance of understanding trauma and how it can affect the actual physical makeup of our brain and how we respond to things that are just simply beyond our control. And the idea of treating trauma is helping us to be able to see what our behaviors are and how we can address them, and so that we can feel safe. Dr. Nadine Burke-Harris is a pediatrician who's featured in the film Resilience. She has a TED Talk, and that one is, I think, 17 or 18 minutes long. She's wearing a red dress, and I highly commend that to you. She is actually now the Surgeon General for the state of California. I mentioned SAMHSA earlier. They have a tremendous amount of trauma resources. The documentary Healing Mean is available online, and that is focusing on Tonya Kane and her life story, and it is such an important documentary to watch if you haven't had the opportunity to do that. And if you ever have an opportunity to see Tonya present, please do. Next slide, please. The CDC I mentioned earlier, the National Child Traumatic Stress Network, just has such good information on it. Trauma Sensitive Schools is looking at trauma from the educational perspective. The Center on the Developing Child at Harvard University, also featured in the film Resilience, has a lot of information on there. And then ACEs Connection, that is sort of a collaborative. Any of us on this call today could become members of the ACEs Connection. Get an email. You can get emails every day, or you can ask them to send them to you once a week, or ever how you want them, but lots of information on that as well. And with that, I can conclude, and if you'll go to the last slide, that's my contact information, and we can take questions if there are any, or we can share good things that have worked in people's individual environments.
Thanks so much, Cass. There are a couple of questions that come to the chat box, but I do want to encourage everybody that if you have some tactics or experiences that you've had that have worked well, please share those in the chat box as we're going along, because I will kind of pull some of those things together and send that information out when we get ready to send the slide deck and everything to everyone. So the first one is actually, it's kind of a comment rather than a question. But this individual noted that they personally feel that the COVID-19 is adding to trauma for people. She's got a relative, a sister who's in a facility who's declining in care, and it's due to the isolation and not being allowed to visit that this is a very traumatic experience, and noted that there's a need for advocacy around this. I didn't know if you wanted to comment on that observation.
Yeah, absolutely. There's no question that COVID has really revealed a lot of inequities in so many different areas of this country, from being able to access health care to the communities that it has affected most greatly based on race and ethnicity, as well as people who are living in congregate care facilities, both the staff and the residents who live there, being subjected to live in places where not only are they isolated, but they are at tremendous risk for contracting the virus itself. So I completely sympathize and empathize with the individual who made the comment. I don't know the type of facility that the individual was writing about, but there have been some loosening of some restrictions with regard to visitation, where they are allowing people to have visitation outside. And this is, there are different relaxations of the visitation based on the type of licensed facility. So, but in general, they are now allowing visitation to occur outside, so long as there can be social distancing. And, but of course, not everybody will be able to go outside, and I fully recognize that. I am hopeful that there is some way for this individual to be able to visit via an iPad or an iPhone to have a physical, be able to see an individual or family members, their faces. There's not an easy answer to that. I think we probably, everybody on this call has been on so many different calls and been in so many different meetings when COVID has been, since COVID began, and there's just simply not an easy answer. And I'm sorry that that's happening.
Well, thank you for adding to that and giving some additional context and everything around it. So the next one is a question, and it asks if you can speak to trauma related to systemic racism or microaggressions in trauma. This person notes that there's some research that suggests that witnessing events, even through, say, social media or the news, can create trauma for Black individuals or people of color. And of course, those of color who have disabilities. And the question is whether or not you have thoughts on how to address this particular situation.
Well, the answer is yes, that is. Trauma, remember, is individualized, and so it's how the individual experiences, that middle E, experiences the event. And there is a lot of research out there, and there is beginning to be more focus on systemic and institutional trauma. There is a term many of you may know of epigenetics, which is how toxic stress from adverse childhood experiences is passed from generation to generation. Sort of, that's what's known as historical trauma. So we know that in this country there are so many different health disparities based on being able to access services and to have the financial means to access all kinds of services. We know that there is, in every system in our country, in the United States, educational criminal justice, healthcare, finance, you name the system, people of color, and in particular Black people, have worse outcomes than white people. So it is a real thing, and depending on how individuals experience that themselves, it absolutely can be traumatizing, and I absolutely know that it does traumatize. There is a book that I can recommend called, if you haven't, I don't know who wrote the question, but if you haven't seen it, I commend this book to you, called My Grandmother's Hands. It is written by, I'm pulling it up right now, Esma Menachem, and it's called Racialized Trauma and the Pathway to Mending Our Hearts and Bodies. And I highly commend that book to anyone who is interested in trauma, looking at it through a racial lens. I don't know if I've answered that fully, and given more time, I think we could have a not just a webinar, but a whole on racism and its insidious effects.
Okay, great. Thank you so much, Cass. And I can get that book title from you and send that, the name of it out and the author name when I send out the slide deck and everything.
Right.
So the next one is really more just kind of a thank you for your comment to the reminder to speak with, of how to speak with a person with a disability using this trauma-informed approach, that showing empathy and actively listening is a great way to connect with someone and let them know that they're a human being with an important voice. So just kind of an acknowledgement and thank you for that comment. The next one is if you could give some examples of good ways to build safety.
Well, sure. So I talked about some of the, in the slides, some of the ways, I don't know, so there's, you can do it environment, it's a really if you think about it holistically, so it's interpersonal, how you work together. It's also the culture of the system that the person is trying to access. And it's also the physical environment, right? So ideally, all three of those things are working together to help a person feel safe and comfortable and honored and centered upon in every interaction. So if you think about, I mentioned Dr. Kevin Ann Huckshorn early in my presentation because she truly is a brilliant thinker about trauma. And she thinks about it from the Walt Disney World perspective. So if you think about Disney World or Disneyland, and that brand is so focused on customer service and customer happiness. And so she says that's really what you really need to be thinking about is, you know, helping people feel that comfortable that they want to be there and that they want to participate because they see it as something that is going to help them to heal. So if you have some specific examples, we can sort of troubleshoot them together, or I'm happy to talk with you offline, but it's basically all the things that I was putting in there in the bullets to think through. What sort of culture you're sort of conveying to people and ensuring that it's not one of control, or authority, or power. Are people walking around with keys? Is it othering? Is it us versus them versus we together or working? That makes sense? I'm sorry, we can't see each other. if that's for you, but I hope that was helpful.
Great, thank you so much. There's been a few other comments that have come in noting the effect of trauma on related to the COVID situation and how facilities are handling situations. And some of them are working with people better than others. So there's a couple comments that have been put through regarding that. Do have one question here of why does treatment last only a short period of time, say 6 months or 12 months, and then it's discontinued? which most often results in the client re-entering treatment soon after being dismissed, and why the state of North Carolina is not recognizing mental health as a lifelong disability.
Okay. I'm sorry, I mean to laugh. It's a really good question. It's just such a deep question, and there are so many systemic issues at play there. It sounds like the person who wrote that in is understanding that. The 6 to 12 months treatment, I'm not sure in what arena that might be, but I would submit that if any treatment that is going on is focusing on the experiences of that individual in the past, the adverse childhood experiences, and working to understand those, that everything else will come into the fold and work together, so that there will be, one of the outcomes I mentioned when you are using trauma approaches, trauma-informed approaches, is shorter treatment periods of time and more engagement that people have in their treatment if they are focusing on the things that are actually helping them to do better and to feel better. So, I would love to see the state of North Carolina start a trauma initiative and, a requirement for all providers to become trauma informed and to shift their entire focus away from whatever focus that they have to a trauma informed focus, and then bring the treatment that they're providing into that particular focus. I think that would make all the difference and get back to that cost savings, right? Because then people are not going to need treatment for as long, and they're also going to begin to heal and to move forward. And we're going to be interrupting that cycle of intergenerational adverse childhood experiences, because as we begin to learn about those, then we can work to break that cycle so it doesn't continue on in families.
Okay, great. And there were a couple comments that came in as you were talking to kind of support what you're saying, that in terms of the amount of treatment, but some of it really does depend on the diagnosis and the modalities that they're using. So it can be situation specific on that. So the next one is, this is actually an experience that somebody had that is working well with a facility, that wanted to kind of share this. And they were talking about at facilities, it's kind of difficult with the new regulations of being outdoors and maintaining the differences. So what this facility is doing to some extent is recording videos and sending the videos, or having the families record videos and then providing those videos to the residents. Wow. Which seems to be working really well. So that's a great idea.
Yeah, that's a great idea. I'm gonna recommend that. I hope you don't mind.
Absolutely, that is a fantastic suggestion. And then a couple of people who have also noted a couple of books that they've found that have been impactful to them. So I'll go ahead and add those book titles also to the email that I sent out. Right. So thank you, everybody, for your comments and your questions and sharing information. This has been really, really great. So as next steps for everybody, I will be sending out a copy of the slide deck, so you've got it via email. I'll combine some of the comments and suggestions and different things and give the additional resources. I'll also give you a link to the recording for today if you do want to either share it or listen to it again. I'll send that out. And then again, a plug for next month's Lunch and Learn webinar with Dr. Jill Hinton. It's going to look at the topic again, but more from a clinical perspective of the trauma approaches. So with that, did you have any closing remarks that you'd like to make, Cass?
No, I was just gonna hype for Jill again, because I was thinking about the question or the comment you were saying that people were talking different modalities, and so it sounds like Jill is going to be a great person to be able to address specific questions along those lines.
Absolutely, and make sure that she has that question. So, all right, well, thank you, everybody. Thank you for joining us, and I hope we can see you on our next Lunch and Learn next month. And thank you again, Cass. This has been absolutely fabulous, and I'm glad that you were able to do this with us. I hope everybody has
a great day. So happy to be able to do it. Thank you very, very much.
All right, well, thank you. Have a great day, everyone, and have a great week. Thanks so much. Bye.